guys, Dr. Nick Ravon, endocrinology, metabolism, thyroid interventionalist. I want to know why we did not talk about a study that we published last year in the Endocrine Society Journal. The Endocrine Society is an extremely large body of society of all endocrinologists in the entire world. And we published it last year. And I had the paper right here in my hand, and I'm going to read it to you and post it on the video so you can guys take a look at it. The title of the paper exactly was Radiofrequency Ablation of Cervical Thyroid Cancer Metastasis, Experience of Endocrinology Practices in the United States. Yes, we were one of the premier practices in the United States to start radiofrequency ablation on thyroid cancer and cervical metastatic lymph nodes. Well, here's the case. You have a patient that comes in who has a thyroid nodule, gets biopsied, gets thyroid cancer, and they elect to go to thyroid surgery. These patients who undergo thyroid surgery now come for their follow-up, and the blood test shows that there is residual thyroid tissue, and the ultrasound shows there is a lymph node, as I will present to you in a case. And the paper that we published right here for you guys. Our study outcomes have been outstanding. Of all the patients that we treated, there has been no recurrence, and the study data looks at over 450 days of follow-up. And now I'm looking at 3+ year follow-up going on to 4 years very soon on those follow-ups, outstanding results with negative thyroid globulin and no lymph nodes noted. If you have lymph nodes after thyroid surgery, your option is most likely what? Go back to surgery. Well, here is a problem. When you go back to surgery, the poor surgeon has to go back in that neck again, and that neck has got scar tissue, and getting into that neck is very difficult because there's scar tissue and adhesions, so the surgeon is going to have a hard time dissecting the tissue apart. The lymph nodes are stuck. It's like sticky glue. Not fun. The surgeons always want to go in there when the neck is clear. But if you want to go back in the neck the second time, it's a big problem, and the reason it's a big problem because of adhesions. Now, what are your options? Go back to surgery. Well, the surgeon will risk you significant risk of morbidity associated with a second surgery. Or you can go radiofrequency. That's exactly what we said 3 to 4 years ago. And we published that paper, which I'll show you on the screen. As you can take a look at this paper, very effective paper based on the outcomes. But here I'm also going to share you with a patient who I radiofrequencied who had a cervical metastatic lymph node who came from another institution who told her everything was fine. She did not know any follow-up. She doesn't need an ultrasound because she was 3 years post-thyroid surgery. And I was like, I don't think so. So we did an examination, couldn't feel anything, did a blood test, didn't see anything. I said, let me do an ultrasound. And I did the ultrasound, and as you can see right here, there is a small nodule, about 4 to 5 millimeters, sitting on her cervical lymph node chain, which is concerning. We biopsied that nodule. The nodule was consistent with thyroid cancer cells based on the pathology, and then we radiofrequency it. And I'll show you exactly how I did it. And we published the paper, guys. This stuff is real. Thyroid radiofrequency ablation is now being applied to these metastatic cancers and also primary thyroid cancers. Tumors are less than 1 centimeter. We have outstanding outcome and data, even on larger tumors, as long as we can get clear borders. That's the caveat that we need to get for these cases. I hope you enjoy, and thyroid radiofrequency ablation is here to stay, and we hopefully expand it to also cervical lymph nodes and also thyroid cancers, tumors or papillary thyroid cancers who are 1 centimeter or less or have clear margins, okay? Here, what I'll show you is the video, is the approach as I'm going in from the transdismic approach. I'm going from the lateral, medial to lateral as I place the radiofrequency probe inside the lymph node very carefully. I position it just right, and I turn on the radiofrequency generator. Here you can see the white material demonstrating ablation of that lymph node. Here you can see a very good success, and this is one of the patients we published in our study in 2021, as I want to share the study with you. So now this patient is exactly 3 years out, doing great, thyroid globulin is negative, etc. So let me present to you the same image again, the video. What would you have this patient do? Undergo thyroid surgery, open the neck, general surgery, general anesthesia, and increase the risk of morbidity and possible mortality with all the complications in the second surgery, or perform the highly skilled procedure interventionally by a skilled endocrinologist to have a procedure done like this. Although we're making it look easy, there's a lot of preparation that goes in to get it just like this, and therefore you can see the needle is inserted into the center core, and then subsequently the generator is turned on with a very low voltage to destroy wattage, to destroy the thyroid nodule by preserving the surrounding tissue. You can see it turns on this white shadow, creates the ablation. As you can see afterwards, there is really nothing left. As we stop the generator and we take a look to see exactly what is left behind, you can see a great success. I would definitely recommend radiofrequency ablation for these patients, as we showed in our study and published data. Thank you.